In this video, we are going to talk about staging. This is actually the third part in a series of 3. We first discussed pathology itself, then grading, and now, finally, staging. With these 3 elements, the diagnosis of a sarcoma is truly complete. Today we have the chance to talk about it with Professor Wardelman, Director of the Institute of Pathology here at the University Hospital in Münster. Thank you for taking the time. I think this is a subject that is not always easy for patients to grasp because it can feel a bit mathematical with so many factors to consider. We also want to talk about the TNM classification. You brought a book with you. Maybe we can even hold it up for a moment.
Yes, of course.
How does the staging process work?
Staging means stage, and it refers to determining the extent of a tumor's spread. It has different components. On one hand, there is the tumor itself, which has a certain size or shape and the way it grows. However, the tumor might have spread in other parts of the body. These can be lymph nodes, which would be the N. The T stands for tumor, the N stands for lymph nodes, and M stands for metastases. If we look beyond the lymph nodes, the liver, lungs, and bones are places where metastases can occur. So that the pathologist, the clinical colleagues, and the different specialties can all communicate in one language, it was agreed that we need a tumor formula that explains automatically, without many words, how extensive or advanced a tumor is. This is why the TNM classification exists. Its purpose is to provide international standards. For example, a tumor that is 4 centimeters in size and located in the lower leg will always receive a specific T stage. This way, if it says T1, everyone knows the tumor is smaller than 5 centimeters. All of this is in this book, which we regularly consult. Please feel free to have a look. The challenge is that it doesn't only include sarcomas, but all tumors that can occur. That is why every pathologist has it on their desk. If a colon carcinoma or breast cancer comes in, it is just as important.
You just mentioned earlier that the T stands for tumor size. As we already said with grading, a small number is better than a large one. We always want, if possible, a smaller number. But the actual size varies greatly depending on the tumor type, whether it is a 1, a 2, or a 3.
No, you cannot say it like that. It depends on the location.
What I meant, whether it is osteosarcoma or something else, or simply another type of sarcoma. Exactly.
In most TNM classifications, there are T1, T2, T3, and T4. 4 is the largest or most extensive category, but in some T4 stages, it is linked to the infiltration of a specific structure, for example, when it grows into the spine. Tumors can also spread locally in very problematic ways. In such a case, a high T stage would be assigned. If it is a small tumor, perhaps even a tiny one, it would be T1.
If we now take osteosarcoma or bone sarcomas as an example, what would typically be the size threshold used there?
There are different size thresholds. Let us have a look. One classification is for soft tissue, and here we have the osteosarcomas. You can see that they are classified quite differently depending on whether they are in the spine or in the extremities.
Yes, okay.
If we take the extremities, for example, the leg, the size limit between T1 and T2 is 8 centimeters.
Which is already quite large.
Yes, quite large. If we look at the spine, where space is much more limited, it is classified by how many vertebral segments are affected. If only one vertebra is affected, or when we look at the pelvis, which is also a very complex bone because it has so many sections, the 8 centimeter limit applies again. But then it gets more complicated. You may see T3A, T3B, or T3C depending on what is involved. That is exactly why we have to check the book. You simply cannot remember all the different T stages. But while we have it open, you might ask, why do I even need this T stage? In the end, it is about saying something regarding prognosis. How aggressive is the disease? Do I need to assume chemotherapy will be necessary? Do I need to assume metastases are very likely? These are the questions. That is why, based on the TNM classification, what is called a stage is assigned. The term staging is sometimes used a bit loosely, and it can be unclear whether it refers only to the TNM classification or to the overall stage. We may still talk about who actually determines it. In principle, the TNM includes this as well, because at the end of each tumor type, it states which T, which N, and which M. It also includes the grading. When I put all of that together, I might arrive at a low-grade malignant tumor or a high-grade malignant tumor. For example, if there is a metastasis anywhere, it is stage 4. Stages are also numbered in Roman numerals 1, 2, 3, 4, 4 being the most serious. We assume that someone with stage 4 disease is not curable. That is why it is important to know whether it is stage 4, meaning there is a risk the patient could die from the tumor, or stage 1, where there is a very good chance of cure.
As we said, M stands for metastasis. Even a single metastasis somewhere is classified as stage 4.
Yes, one must now say we just talked about osteosarcoma. In fact, especially with osteosarcomas, which are often treated very aggressively with chemotherapy in many cycles, even when metastases are present, these patients can often be cured. Therefore, the dogma of saying that stage 4 always means death, roughly speaking, no longer applies in such cases. You cannot put it quite like that. It depends on how effective the therapies are for the specific tumor subtype. If the therapies are effective, it is possible to achieve a cure even in stage 4. But of course, the risk of becoming ill again, meaning a relapse, is much higher in a stage 4 case than in stage 1.
One must also say that this all developed a bit historically.
Exactly.
I think back to the time when stage 4 was viewed so negatively that people would say nothing more could be done. Death was at the door. That was decades ago. Fortunately, therapies have advanced significantly, and there are now many more treatment options, even for different diseases, with therapeutic approaches that can be very effective.
Absolutely correct.
Now, we have skipped the N a bit. It is not just about whether a lymph node is involved. The N can be a little confusing because it refers to lymph nodes, and in English, it stands for nodes. I believe that is where the N comes from. And here it is more about how many lymph nodes are affected, correct?
Yes, generally speaking, in sarcomas, the lymph nodes are not as significant as they are in other organs. In the breast, the intestine, or other organs, the lymph node situation is extremely important, because these epithelial gland-forming tumors often spread to the lymph nodes. With sarcomas, this is the absolute exception. There are sarcomas that do metastasize to lymph nodes, but very rarely. That is why we often do not place much importance on this final stage, and lymph nodes are not automatically removed, because it is assumed that the tumor must have already reached the lymph node. That is why the N is not as relevant in sarcomas. Otherwise, N is important, but not in sarcoma.
Now we understand what T, N, and M stand for. The question is, how is that actually determined? Which methods are used? How do you arrive at this classification?
Exactly. That is indeed the task of pathology. Because who measures the tumor size? You might think the radiologist could measure it if they have taken an image. That is not the case. The standard for establishing the TNM classification, meaning for determining the stage, is that pathology measures the maximum tumor diameter. So, and then of course, there is also the question of the other parameters. Are lymph nodes affected? We can only answer that if we receive some. If lymph nodes are sent to us, we can check whether the tumor is present in them. With metastases, it is a bit more difficult because that information usually comes from the clinic. If we do not receive a sample from a liver metastasis, we cannot know that one exists.
Of course.
In this respect, at the end of the day, if you know, okay, the tumor was a certain size and perhaps there were even lymph node metastases, although unlikely, and we have a grading, then imaging essentially comes into play. This often begins locally for the tumor, but then we also need to know if there are metastases. This is often referred to as staging, where CT scans, MRI, PET-CT, sonography, scintigraphy, and other methods are used depending on the type of tumor to determine how far the disease has spread. The question is whether the person already has metastases somewhere. The brain can also be included in this assessment. In this way, a certain standard is followed according to guidelines. For osteosarcoma, specific examinations must always be performed. For leiomyosarcoma, others are required. It depends on the tumor type. The question of which examinations need to be performed is often discussed in a tumor board, meaning interdisciplinary discussions with all colleagues. The pathologist is also there to explain their findings. Radiologists are present as well and can advise on which additional methods should be used. And the surgeons might request further information regarding the local relationship to bones, nerves, and vessels.
Yes, sure.
And that determines how the treatment will proceed.
I think it is very important to emphasize that all of this should take place in a sarcoma center. Absolutely, because only there are the people who truly know this, who have seen and treated it many times. So to all patients who are not yet in a sarcoma center, now is the time to go.
Absolutely. And the reason is that if we stay with bone sarcomas, the diagnosis is not really possible without radiology. Pathologists also rely on having the radiological imaging, which ideally should already be included when material is sent for a second opinion. It is also important for questions such as whether the tumor is more benign or malignant, and how radical surgery should be. How radical can we be while causing as few complications as possible from the operation? All these questions can only be properly answered at a sarcoma center. There are also procedures where neoadjuvant therapy, meaning therapy before surgery, is given. This can be radiation and/or chemotherapy to shrink the tumor. Ideally, this is possible when you have the correct diagnosis before surgery, and also the personnel and access to clinical studies. That is another point, because you cannot do that everywhere. Innovative therapies are therefore preferably carried out in sarcoma centers, as they have the necessary resources, unlike a small community hospital.
That is right. And now we have said that we have done the staging and the grading, and you have used the term tumor formula. I must admit, that sounds a bit unusual to me. What does it look like, and what does it mean?
That is a bit of a casual term. More correctly, one would say tumor classification. Tumor classification includes all parameters, the primary tumor, as well as metastases in lymph nodes or other organs. A complete TNM classification has these three components, and they naturally depend on different people. As we have already said, metastases must be confirmed through imaging. I cannot write PM0 in my report. Only M0 means no metastasis.
And what does P stand for?
The small p for pathology.
Okay.
There are various small letters that can appear before the actual T, which can also be a bit confusing. So, before I get involved, diagnostics must first take place. Someone comes in with a lump on their leg, and then imaging is done. The clinical colleague will assess what stage this might be. Based on the size, for example, they will determine a t-value and put a small c before the formula for clinical. That is why there is a small c at the beginning. When I then receive the tumor and measure it definitively, the value may change because it has become larger or smaller. And then I write a small p.
The C is removed?
P replaces it, yes. So there is a clinical formula, and then I create the pathological formula. There are also two other letters that may appear. Before the small p, there can be a small r for recurrence, meaning the tumor has returned and is different from the primary tumor. Or there can be a small y if it was treated with radiation or chemotherapy before surgery and has shrunk. I can also represent that in the tumor formula. The small y means status post-neoadjuvant therapy, meaning status after pretreatment.
And what does Y stand for exactly?
I stands for Y exactly.
So now we have the C, the P, the R, and the Y. Then it continues with the T, N, and M, each with a number after it. For example, T3, N0, and so on.
Yes, correct.
And where does the grading fit in?
Grading comes at the very end. It does not necessarily have anything to do with TNM itself, but it is still considered in staging and therefore cannot be ignored.
And as a patient, do you even see that? Are you shown this formula?
When you receive the report, yes.
Is it written like that?
Yes, it is listed at the bottom. And then there is often more information there, which can make it a bit more confusing. The idea is that everyone is talking about the same thing, using the same terms and references. Ideally, a leiomyosarcoma receives a specific number that uniquely identifies it within an internationally recognized system. I will explain how it works in a moment. When I record this number in the report, the next treating doctor can immediately see, without any ambiguity, exactly which tumor it was, and proceed with treatment based on the same understanding. These numbers are part of what is called the ICDO coding system. They encode the diagnosis as a sequence of numbers that is the same internationally. So if I say that the tumor has the code 8822, I know it means fibromatosis, and a doctor in America will also know it is fibromatosis. These codes are useful because they are not tied to words, but to numbers, so they cannot be misinterpreted. For such ICDO coding, you first specify the organ, let us say small intestine, and then add the morphology code. That is M for morphology, followed by 4 digits. After that comes a slash, and then you write whether it is malignant, benign, or somewhere in between. So a lot of information is contained in just a few letters and numbers.
Okay, wow, that sounds really complicated.
Yes, it is also a bit formulaic. When you first read TNM, for example, PT2, PN0, parentheses, 0 of 12, you might think, what does all this mean? But it is all about standardizing and structuring the information so that every treating doctor understands it in the same way.
And now, a bit of a silly question. Which of this is really important for the patients?
Everything.
Everything? Really? So, as a patient, should you really try to understand what all of this means?
We keep having this discussion about how deeply someone should get into the subject. It is a very difficult question because it keeps becoming more complex. If we look at the whole area of molecular pathology, even we do not understand everything to the same depth and breadth. And if every patient wants to understand all of the molecular substructures, that is sometimes not even possible. Of course, there is the expectation to be able to discuss a particular issue on equal terms, and that is understandable. But it is different if you have been treating or studying sarcomas for 20 years, compared to facing such a disease for the first time as a patient. Bridging that gap is not easy, and it is not always wise because with all the opportunities to read up on the internet, you can overwhelm someone by expecting them to understand every detail, down to the last molecule.
But now, that is just the right keyword. We have talked about this formula, which does sound a bit confusing. As a patient, I receive a report from you, I look at it, and there is a string of digits and numbers. If I want to look it up now, do I just use a big American search engine and find something? Or do I find nothing?
Yes, you'll find.
So I do not have to buy the book. And if I did buy the book, would I even understand it?
Well, it is of course a specialized book. But if you enter TNM classification into a large search engine, you first get some general information about it. Then it depends on which tumor you want to look up. Often you would need to add sarcoma after it, and then you immediately find the TNM for sarcomas.
Okay.
And then you will see later that T1 is this, T2 is that, and so on.
And now we have these tumor formulas, but then there is also a definition of the stage. Is that the result of this formula, meaning the stage?
Exactly, because the degree of malignancy, for example, is included there, which is not in the TNM itself. So in a way, it is a summary or conclusion for further therapeutic steps. And when you look at guidelines, they often say to do this at stage 3 or to do that at stage 4. For clinical colleagues, it is often the guiding framework for deciding whether to treat more aggressively or less aggressively. We ourselves often do not assign the stage, as I said, because we do not always have all the information. For example, we may not know if metastases are present at diagnosis.
So, just to say briefly in advance, there are 4 stages: 1, 2, 3, and 4. And I suppose 1 is the best.
Exactly.
So that means you can do the tumor formulas, but the final stage might need to be determined by the clinical colleagues because only they know whether metastases are present.
Yes, ideally we do this together because we meet once a week for a sarcoma tumor board. Only sarcoma cases are discussed there. Benign cases are also discussed because it may turn out that the tumor was benign. In that case, we can say, okay, the patient is now cured and can go home. So, and otherwise, this sarcoma tumor board gathers all preliminary findings. That means there is always a radiologist present who knows what the imaging has shown. Are there perhaps still nodules in the liver? Should we maybe even biopsy them again to ensure that they are related? In these conferences, all the findings are brought together. A radiologist is there who knows what the imaging has shown, whether there are still nodules in the liver, and whether a biopsy might be needed to check if they are related. That means there is a whole group of people involved. These days we do most of it online, so we no longer meet in person. This is a leftover from the Corona period, when we became much more practiced in handling it online. We meet virtually, review the images and the cases, and also determine the stage.
The conclusion is the therapy decision, or more information is needed, and the case discussed again.
Today, the case must be discussed before treatment. Later, for example, after surgery, it is reviewed to confirm tumor size and diagnosis, so it is not unusual for a patient to be discussed more than once in the tumor board.
Now we have talked a lot about this formula, TNM, grading, and so on. It might seem like that is the main focus, but in fact, the type of sarcoma is probably even more important, right?
Yes, it is certainly very important, because the biology is not the same in all cases. We all know that. There are situations where, if we can determine the subtype, we can already say whether the outlook will be very poor or whether it will be a tumor that is less problematic. And in this respect, we also know that grading cannot be applied equally to all tumors. There is a growing effort to develop scores that move away from G1, G2, G3 toward categories such as high risk of relapse or low risk of relapse, and then tailor the therapy accordingly. This approach allows therapy to be tailored accordingly. Why do you do that? You can include factors like age and size. You can, of course, also consider metastases and necrosis, but you can also include other important parameters, and this is done in a subtype-specific way. That means the liposarcoma may eventually be given a different prognostic approach than the leiomyosarcoma, because we have learned that they should not all be grouped together, and that the mitotic thresholds can also be very different. We always have these fixed standards, always the same number of mitoses, but perhaps that is not even appropriate. That is why subtyping is so important for further treatment planning, therapy, and prognosis.
Thank you very much. I think that was a very good closing remark, because it clearly shows that we are in an ongoing process, and fortunately, a great deal is happening, not only in therapy, but also in pathology. That is an excellent foundation for further progress. So many thanks, Professor Wardelman.
With pleasure.
For the insight you have given us into all these processes. Thank you.
Thank you as well.